Good afternoon, and thank you for joining An Unexpected Fight, a pediatric cancer podcast. I know it's been a little bit since we have recorded an episode, so I am super excited to be back today with Kelly and Dr. Larkin. Dr. Larkin, thank you so much for being here. Kelly, why don't you tell us a little bit about our guest?
Yes, so I'm very excited for this one. This is Dr. Trisha Larkin. She is the Director of Pediatric Neuro-Oncology at St. Joseph's Children's Hospital. She is dual board certified in pediatrics and pediatric hematology-oncology. Dr. Larkin earned her medical degree from Florida International University College of Medicine, followed by a master's of business administration and healthcare. She completed her postdoctoral training at Nicklaus Children's Hospital and the University of Florida Shands Children's Hospital, where she completed a fellowship in pediatric hematology-oncology and bone marrow transplants. She went on to complete a prestigious advanced fellowship in neuro-oncology at St. Jude Children's Research Hospital in Tennessee. While at St. Jude, she worked on a team of world-renowned physicians to care for children diagnosed with complex brain and spinal tumors. Dr. Larkin is passionate about discovering innovative strategies to improve the care of children with brain tumors and serves as the lead investigator for the Sunshine Project Consortium through the National Pediatric Cancer Foundation. She has been awarded numerous grants for her research in early phase clinical trials and has authored several peer-reviewed publications in leading oncology journals such as the Journal of Clinical Oncology and Neuro-Oncology. Dr. Larkin has been invited to present her research around the world, including in Germany and Japan. She serves as associate editor for Neuro-Oncology on the MedNet, an interactive platform for physicians around the world to gather insight about treating complex oncologic disease diagnoses. Dr. Larkin is deeply involved in the pediatric cancer community and enjoys volunteering her time to support childhood cancer. That is an extremely impressive bio. And I, for one, am a little biased because Dr. Larkin was one of my daughter's treating oncologists. So I've been very, very excited about this interview because she is one of my heroes. So Dr. Larkin, not to put you on the spot there, but can you share a bit about your journey and what inspired you to specialize in pediatric neuro-oncology?
Well, first of all, thank you guys for both having me. I think the work that you're doing with this podcast and with your advocacy through the Sunshine Project and National Pediatric Cancer Foundation is incredibly important for advocating for our children and what we do. So I kind of grew up knowing that I wanted to be a pediatric oncologist. So I spent a lot of time as a patient in hospitals myself when I was younger. And pediatric cancer was always, a personal passion of mine because of how I was affected by it. One of the things that I think is fantastic about what we've been able to do in the pediatric cancer world is we've really made a lot of sort of watershed landmark movements towards improving our overall prognosis and our treatment options. But we necessarily haven't done that in pediatric neuro-oncology. So, we hear pediatric cancer survival rates approaching 95, 99% in some of our leukemias. But one of the things that, I came across during my training in pediatric hematology-oncology was really, what are we doing in neuro-oncology and what can we do to help improve the outcomes of the kids that we treat? I think right now in the current era, it's just a really exciting time for our kids who have brain and spine tumors. We are looking at tumors in a way that we never have before with all the fancy diagnostic technologies that we have now, like next generation sequencing and methylation profiling, which have really just changed the way that we approach our pediatric brain tumors. It used to be historically that we would think about brain tumors in kids as, high grade or low grade. And we would just give blanket treatments to these kids that were really invasive and had a lot of long-term effects. But one of the things that we're doing now is, we're learning more about what actually is driving the tumors, and we're able to kind of target that and use precision medicine to improve our treatments. So I think right now it's just a really fantastic, amazing time to be in the world of pediatric neuro-oncology.
So do you think they're going to change how they grade and diagnose pediatric brain tumors based on molecular diagnostics? I mean, do you think they're still going to do low and high grade?
So actually, we kind of already have in the brain tumor world. So back in 2021, the World Health Organization did a massive regrouping of how we think about brain tumors in children and in adults. So a lot of our new diagnostic terminology and approaches are really based on that molecular information. So we're really kind of changing the terminology of low grade and high grade and kind of getting into these more intricate integrated diagnoses that are looking at, yes, the histology, what do the cells look like under the microscope, but also that are starting to integrate these molecular findings into how we're approaching the tumors, and we're learning more about how those findings actually affect how these tumors act.
I love that.
That's crazy
So what do you
think how quickly that's happened. I still think of Riley as being kind of new out of treatment, but she was diagnosed in 2020 before a lot of this already started happening. So it's crazy to see just in the last few years how much has changed.
Exactly. And Kelly, just from our experience and experiences with your daughter, we kind of started integrating those things and talking to you about those things even as she was going through her treatment. So that kind of just speaks to how much things have really changed. And that also kind of speaks to why it's so important to really understand what we're doing in the field of pediatric neuro-oncology.
Absolutely.
So what do you think is the most rewarding part of your work?
100% it's working with the kids and being with them every day. You guys both know, as moms who have been through this, that there's no one stronger than a kid who has cancer. These kids are going through neurosurgical procedures, they're having ports placed, they're getting chemo infusions, and they are running around the infusion center, running around the floor, running around clinic, just acting like completely normal kids. And sometimes you wonder sort of where they get their strength from. So it's definitely just so rewarding being able to see them handle these things that most adults would just be knocked in bed for days with. And I think a big part is just getting to build the relationships that we build with the families as well. So in pediatric oncology, you're not just treating a patient, you're treating the whole family. You're getting close to siblings and learning about how these kids are growing up and what's happening to the sisters and what schools are they going to and things like that. And it's very rewarding to feel like you're making a difference.
Absolutely. Speaking of adult cancers, that's something Tiffany and I don't like hearing when somebody's trying to relate to your experience. They say like, oh, my grandmother had cancer. And I don't know how to explain to them how very different adult brain cancers or any adult cancer is in comparison to pediatrics. So that really leads into my next question. Can you explain what makes pediatric brain tumors unique compared to those in adults?
So what we are learning more and more with the testing that we're doing now in diagnostics is that there's just different drivers to our pediatric brain tumors. Historically, we used to think about the impact of treatments on the kids and just the fact that their brains were still developing and growing. But now we're actually understanding that the epigenetic findings and the drivers of what is causing these tumors to grow, to sometimes recur, to metastasize, and sometimes to not respond to treatment is really drastically different than what's happening in our adult counterparts. The other kind of huge thing to remember about pediatric brain tumors is our kids, their brains are still developing. The impact of both the tumor location and the treatments that we give definitely have to be considered in approaching how we actually develop our treatments. Tumors in kids can cause different cognitive, motor, sensory, learning deficits as kids grow. And one of the big things is, as we are improving our survival rates, we also need to work on improving and putting a focus on how are we ensuring that these kids are actually getting an excellent quality of life with the treatments that we're offering.
Absolutely. Even as a nurse, yes, I understood that pediatric cancer was very different than adult cancers, but the first time it really ever hit me how different was when Dr. Gajar, and I had that first phone call with him, and he said, if you look at a glioblastoma under a microscope, if you're looking at an adult versus a pediatric or infantile, in Riley's case, it's like a different tumor. And that's when it really hit me. Wow, I never realized how different they were molecularly. So it's very interesting. And I've done some research on it since then, but But yes, thank you for sharing that.
Yeah, I think that's definitely an important point to bring up is, we have these blanket terms for diagnoses. So glioblastoma, there is infantile glioblastoma, and there's childhood glioblastoma, and there's adult glioblastoma. And all three of those act very, very differently, and they respond to different treatments. So if you're approaching an infant with glioblastoma with the same lens that you would be approaching, an adult with glioblastoma, then you're not treating them the right way.
Right.
And you're not really doing what you can to ensure that kid has a very good quality of life with their treatments.
Absolutely. Oh, Tiffany, you're muted.
That's not helpful, is it? I said, kind of speaking on those same lines, how do you feel like the advancements in genetic and molecular profiling have impacted diagnosis and treatment of the pediatric population? I know in adults there's different, molecular signals that can definitely impact treatment planning and prognosis. So tell us a little bit about how you feel about all of that.
So, I think what we've been able to do with diagnostics is really impressive. And some of this has happened even from the time that I was a trainee to my time in clinical practice. We are now approaching our pediatric brain tumors with the molecular and integrated diagnosis in mind. So when I mention kind of this blanket term of integrated diagnosis, it's the histology. So, what do the cells look like under the microscope, and what have they historically been called? That's sort of when we're talking about these low grade and high grade gliomas, pilocytics, using that terminology. But now we're actually looking at those molecular drivers. So we're able to, prescribe targeted therapies based on some of the findings. We're able to look at what types of immunotherapies can help, or what we would expect these tumors to respond to or potentially respond to. So in pediatric brain tumor world, huge emphasis has been placed on targeted therapy. And I would say sometimes it's even considered for frontline therapies now for our kids versus our traditional chemotherapy approaches, which of course have tons of toxicity associated with them. So a huge development in our pediatric brain tumor world has been the kind of discovery and emphasis that's been placed on the RAF pathway, which is sort of where our MEK inhibitors and our pan-RAF inhibitors, and sort of that class of medication that everyone's hears about quite a bit now, those have opened up an opportunity to understand both point mutations and fusions in the tumors and help us actually target them correctly. There are now FDA approved options. They're very accessible for families. These companies are working really hard to get their medication to help. And they're really making just an immense difference in how kids are actually functionally developing after their treatment or during their treatment. So it used to be that, a low-grade glioma with a BRAF fusion or a BRAF V600 point mutation would be getting vincristine and carboplatin, which are two of the most ancient drugs that we have in pediatric oncology world, because those are two drugs that we know penetrate the blood-brain barrier and are able to get into the space that we need to treat our brain tumors. Now, a lot of these kids are, those treatments came with central lines, weekly access, came with kids having to come into the infusion center, miss school for whole days, potentially miss school days after. One of the things that we used to see a lot was peripheral neuropathy, and peripheral neuropathy, of course, affects both motor and sensory development of a child. It's good to know that those things, if patients are on those frontline therapies and they're not responding, or if they have a really good option with a targeted therapy, that we're able to save them and spare them from those toxicities. I was actually on a call last week with a few of kind of the folks that I would consider to be the godfathers of pediatric neuro-oncology, and Dr. Goldman, who a lot of people recognize his name just in our world in general. He mentioned it's kind of a beautiful idea to think that we might be in a world where low-grade gliomas are no longer having the horrible peripheral neuropathy that these kids used to historically develop with drugs like vincristine and vinblastine.
Right.
I mean, there's other cool, oral drugs I think that have come out, I think probably in the older pediatric population, but into adults, like these IDH1 inhibitors and, all of these cool things that are starting to come out. I'm really excited to see that they're crossing some of these oral agents over to the pediatric populations, because historically our kids aren't getting much in way of new therapies. So I think it's really exciting to see some of this start to come to fruition.
Absolutely. And historically, there's a lot of data that shows it takes anywhere between 7 to 9 years for a drug to span from the adult world into the pediatric world. But where adult oncologists and companies that are developing medications for adult tumors are now realizing, well, if breast cancer and melanoma can metastasize to the brain, why can't we use some of those same targeted approaches to treat brain tumors up front? So it's been really exciting to kind of see that bridge finally coming to place where we're transitioning things from the adult world to the pediatric world.
Absolutely. And Tiffany and I have talked about this on previous podcast episodes, but for those who are listening who don't know, when we say ancient chemotherapy drugs, a lot of them are from like the 40s, 50s, 60s. So to me, that's pretty ancient when you think about how many new drugs are developed on a daily basis. I mean, just turn on the TV and it's a new commercial for a new whatever diabetes medication or blood pressure medication, or it's every day hundreds are coming out. But in the pediatric cancer world, it's been a little slow, so it's really great to hear the progress that's happening. I know Tiffany would tackle somebody over this topic, but genetic and molecular profiling, we've actually heard from other physicians too that they're hesitant to do deep testing on these kids because a lot of times you don't really come back with a treatable mutation. But Tiffany and I think, would both argue that, well, if you get enough data set and you test enough, then won't you eventually develop these patterns and start to find these treatable mutations? What are your thoughts on that? Because we would argue that till we're blue in the face.
I would absolutely agree with you guys in that standpoint, because if we're creating large enough and robust enough data sets kind of pointing towards mutations, even if we don't have those targeted therapies for them now, pharmaceutical companies are becoming more and more interested in actually talking to researchers, and coming to meetings like the Sunshine Consortium that we do twice a year. And they're actually starting to approach us finally as clinicians and researchers in the pediatric oncology world with sort of this, we have a molecule that might target this. Do you think it could be effective? And historically, that's something that used to never happen. Historically, companies would kind of develop these drugs and these medications and compounds for adult cancer, and they wouldn't necessarily bridge automatically to the pediatric world. So I agree. I think getting these robust data sets, I find where the hesitancy comes from some physicians is this is newer technology. And some physicians may find findings that they're not sure what to do with it. And in those cases, one of the really beautiful things about our field is that we're so collaborative. So even if you are kind of questioning, should I send this? There's usually someone that you can reach out to. No one knows everything. And there's usually some researcher or some clinician in a specific area that you can reach out to, and you can kind of ask, would it be beneficial for me to try to get this information on this patient? Right. One of the really wonderful things that's come out for pediatric brain tumor world is something called the Molecular Characterization Initiative through the Children's Oncology Group. So our colleagues over at Nationwide Children's in Ohio have really dedicated their lab expertise to being able to do this comprehensive molecular profiling for our brain tumors. They've extended that into solid tumors, but of course, as a pediatric neuro-oncologist, I'm definitely more familiar and well-versed with what they're doing for our pediatric brain tumors. But essentially, because we've identified that these findings are so important, or that they could potentially be so important in how we approach these kids, a lot of emphasis is being placed on how do we learn about that. So I think the best way to do that, of course, is in a centralized collaborative manner, which is what they've been able to do. So with families consenting to a Children's Oncology Group sort of registry, it's called Project Every Child with APAC. If your child has certain types of diagnoses, so these specific diagnoses that we're looking to learn more about the molecular findings for, will actually do this comprehensive characterization of the tumor sample and of germline sample, so non-tumor sample as well, so that we can learn more about both the tumor, potential targeted approaches, but then also what genes are happening in just the other blood cells of this patient to help possibly correlate some of the tumors with some of our genetic features.
Do you feel like they're doing this a lot more for kids who are advanced or metastatic disease based versus earlier stage?
So actually, with brain and solid tumor, so solid tumor meaning like our sarcomas or rhabdomyosarcomas, we're actually starting to do it a little bit more upfront as well. I definitely think that when kids are relapsing, there's benefit to resending some of that
Yeah.
information because, as you guys know, tumors can develop new mutations and the tumor microenvironment can change with different types of treatment. So I think it's important to do it both upfront and at relapse or metastases or recurrence, because there might actually be something that's changed in the tumor. And maybe at the opportunity of relapse, when it's done, we identify some type of epigenetic driver that we didn't notice before.
Yep.
Or maybe it wasn't before.
I feel like you're very advanced on some of this. There's been multiple pediatric oncologists that I've talked to who only test at advanced or metastatic disease. And, working in the adult setting, I've been doing this for 13 years now. And I remember when we used to just test EGFR for lung cancer, we'd have to send it out as this single IHC order, and you'd send it to the pathology lab, and then you'd have to wait a month or 6 weeks or however long to get this one result back. And now we can send off full genetic profiling and have it back in 2 or 3 weeks. And I think that the frequency that we've said occurs in a patient has changed significantly over the last 10 years as we continue to do these tests. They say, oh, well, this is only 2 to 3% of the patients are going to have this mutation, but really now over 10% of lung cancer cases have EGFR mutations. So that's kind of how I feel in pediatrics, how I feel it will eventually be once people start doing the testing. They're going to realize there are a lot more drivers than they are going to expect, I think anyway. But I love that you're doing that. That's amazing. And I think that you're providing top-notch care for these kids. So it's just super cool to hear.
Thank you. And I think initiatives like the one through Children's Oncology Group and through some of the things that we're trying to do in the Sunshine Project as well have really allowed clinicians and researchers to kind of come to the forefront of this, collaborate, and start creating some robust data sets.
I remember you telling me about, creating and trying to collect more data and retrospective data to really kind of see these, the different mutations and, start to kind of just gather. It's really about the more data you have, the more you understand. So can you tell us more about that, your involvement with the National Pediatric Cancer Foundation, the work you're doing with the Sunshine Project Consortium, and any trials or research that you have going on?
Absolutely. So one of the things that I'm involved with very heavily with the Sunshine Project is leading a pillar called our Novel Initiatives pillar. And specifically, one of the studies that we have open through that is a project that's called Retro Total Cancer Care, or Retro TCC. And essentially what we're doing is we are gathering retrospective data on how people have approached some of these harder to treat solid tumors and brain tumors. So historically, because of the rarity of pediatric cancer, you might have 1 or 2 individuals in certain institutions who've treated a ton of these patients, but then you might also have a handful of institutions that maybe have only treated 1 or 2, but it's really important to learn both from the experience, what did we do right, what did we do wrong, and what did we learn? Mm-hmm. So a lot of folks will think of the country as having sort of these pillar institutions, St. Jude being one of them, of course. But what most folks don't realize is there's over 100 tertiary pediatric cancer institutions in the country. And oftentimes, those institutions are also treating kids that can add to our knowledge as a whole. So when we talk about the collaborative nature of pediatric oncology, one of the things that Sunshine Project's really trying to do with the Retro TCC initiative or project is we're trying to pull together the experiences that folks have had treating tumors that are historically thought of as difficult to treat. So we're focusing specifically on different types of sarcomas, things like Ewing sarcoma, desmoplastic small round cell tumor, where kids, maybe we have a standard of care, maybe we don't have a standard of care. In the cases where we don't have the standard of care, what if folks actually have experience doing, and what can we kind of pull together, compound, to help direct sort of where we move our research efforts for the future.
Do you see yourself doing that also in the neuro-oncology field and kind of starting to collect? I feel like it's a little harder because I know the numbers aren't there quite as much, but we know, Tiffany and I probably are a little biased, but it's more kids than people realize are diagnosed with cancer, and even with brain tumors. So do you see yourself kind of focusing on neuro-oncology with that in the future?
Absolutely. So, historically, the Sunshine Project did, focus on more sarcomas because it was started and led by Damon Reed, who's one of our just most amazing researchers and clinicians for pediatric sarcoma. But as the consortium has grown, the consortium has really been focused on improving the outcome for kids who maybe historically have not had that great outcome. Mm-hmm. And what we know is brain tumors are included in that. So as the consortium has grown through, the decades that it's existed, we have started to pull more pediatric neuro-oncologists like myself into this group. So what we hope to do with Retro TCC is kind of initially pilot in that initial group of sort of sarcomas that the consortium was really founded to focus on, and eventually start pulling in neuro-oncology too. So we're working on building sort of this research database through Moffitt Cancer Center that is really going to allow us to kind of continue to build on. So we're currently building it more towards sarcomas with the plan to eventually branch that into neuro-oncology diagnoses as well.
I've always said, why can't we just have a centralized database? And I know financially there's a big holdup, but I think there's other reasons too. And it's hard for a provider to give up all of their hard-earned research and data to somebody else who wants to do like a centralized database type thing, because now that's not their name on it anymore, if that makes sense. So how do you think that's feasible to have, like a centralized database where we can dive in and see data from, like you said, multiple institutions around the country, multiple patients? And what's been the holdup thus far that we don't have one?
So I think a massive piece of the holdup has really been, we haven't had sort of this consortium full of wide amounts of expertise actually coming to the table. So one of the really beautiful things about the Sunshine Project is you don't have to be a certain person to be invited into it. Our group includes some of the top senior investigators and most well-renowned and well-recognized clinicians around the country. But our group also includes a lot of young trainees, folks who are new to the field, folks who just are coming in with a lot of new knowledge and really enthusiasm about what we're doing. So it's a unique workspace in that all of these folks are kind of coming together in a room. We're welcoming parents like the two of you into that. We're welcoming pharmaceutical companies who are developing drugs and trying to figure out where's the next big idea. And one of the really unique things that comes up during these meetings is there's never necessarily a definitive plan, right? We don't have this hardcore agenda. These are the things that we have to accomplish to be able to report back to a certain board that we've done certain things. It is a open format where people are coming with ideas, and the question is, what can we do next? It's not the question of what boundaries do we have and what barriers do we have. The Sunshine Project, National Pediatric Cancer Foundation, does an amazing job of raising the funds that come into place and that are needed for pediatric research, so that if we come up with the next great idea, or when we come up with the next great idea, we never have to worry about sort of what are the bureaucratic steps to being able to really get that idea launched, and how do we support the people that need to move this idea forward. So I think being able to come into a group with that collaborative mindset, our database is not about this person leading it or these particular people leading it. It's everyone is allowed to contribute. All you have to do is fill out your IRB paperwork and kind of make sure that your site gets approved, make sure that we're consenting patients appropriately to add their data to the database, but everyone can contribute. And that's a beautiful thing that we maybe haven't had to this level, specifically looking at these types of diagnoses in the past.
Does AI play a role in this at all? Like, is AI going to help with sorting and, kind of finding these trends in data? I know I've heard a lot of people talk about AI, and I know it's still so new. But
that is probably a question for a different session. And that's probably
a whole other podcast episode.
So that's really interesting. I just got back from JADPRO, which is a nationwide advanced practice provider and pharmacy conference for oncology, and we did a whole seminar on AI therapy and like how AI is going to influence therapy in the future, because there's so many systems being built right now to integrate data. And I think that's honestly really exciting for pediatric cancer patients, because we're going to take a lot of the guesswork, a lot of the logging, a lot of the, hey, you add your data here and you add your data there, and the different databases. And then hopefully it's going to be able to pull in all of that data and really highlight some things that are potentially missing that we don't know about.
And with that, I think it's also going to be important to kind of look at, what are our failures too, right? Because it's so important to learn from, what didn't work in the past and how do we change that to things that will.
Yes, I love that. So is there any like groundbreaking neuro-onc stuff that's coming out for kids at this point in time?
Gosh, I feel like everything we're doing in pediatric neuro-oncology is groundbreaking at this
point.
So, a lot of folks will hear these kind of blanket terms like precision medicine and immunotherapy sort of tossed out there. I think really what we've done with diagnostics, so what we've done with next generation sequencing and methylation in pediatric brain tumor world has been huge in terms of where we go next with our therapies. So one of the really exciting things that I think is starting to come out, and there's a few clinical trials open around the country, is looking at CAR-T therapy for our pediatric brain tumors, specifically our relapse and historically difficult to treat tumors. CAR-T, back when we used to talk about it for leukemia, initially it was sort of this crazy idea, like, how is this going to work? How are we going to actually harvest the immune system and T cell function to target these cells? And we've just been able to learn so much about these specific epigenetic changes in tumors that, we now have a brain CAR-T, which is, something we never really thought we would ever have. And we know that it can be successful because of the success that we've seen in pediatric leukemia world. Mm-hmm. CAR-T in pediatric leukemia is now considered, one of the first line options.
Standard, yeah.
For kids who relapse. And I just know there were a lot of skeptics for immunotherapy and CAR-T in the brain tumor world because of the challenge that we reach with trying to get into the blood-brain barrier. So I would say the immunotherapy space, and specifically CAR-T, is something that's really exciting, that's currently available in certain centers. And it's just going to be really interesting to see how that changes what we do.
Interestingly enough, I actually donated $25,000 to a GPC2 CAR-T for ETMR trial that they were doing, and I did it back when it's preclinical, and now it's moved into phase 1, and it's just so exciting to see whenever that happens. Like, oh, we've got this big idea, we think it's really going to work, and then when it actually gets moved into human trials, you're like, yes, okay, we're finally getting somewhere. With all of this new data, with all this information that we have, we're really making some progress here. Because I feel like in pediatric oncology, all the progress has been made in leukemia and lymphoma, like you were saying earlier. But, all these poor kids with brain tumors were really, really behind. I mean, whenever Nora got diagnosed, her survival was 5% at 12 months. And that's not acceptable. It's just not. And there has to be more that we're not learning or doing, or, there has to be something else that we can do. And so it's really exciting to see some of this stuff really start to come to fruition after only 3 years.
Exactly. And that kind of highlights sort of what I was alluding to earlier with how fast we've been working in pediatric neuro-oncology and what an exciting space it is currently.
We just went back for scans. All is well. Scans are stable, but I met a few new brain tumor families while we were there, and the amount that were doing immunotherapies and targeted treatments was mind-boggling to me, because I'm like, that wasn't big when we were in active treatment. That wasn't even really an option for brain tumor kiddos, but it was, I think 2 out of the 3 brain tumor families I met were doing like a targeted therapy, and it made me very happy for them. I wish that was an option for us back then, but it made me happy to see that that's changing, that's happening, and that these treatments are coming out. And it just goes to show, don't overlook like this preclinical research that people are doing, or like you said, these young investigators, because you never know which one. Like CAR T was crazy to think about, and now look at it. So you never know which idea might actually take off and go somewhere. So I think we kind of answered this question, but can you explain for maybe the layperson or families listening the importance of clinical trials in advancing treatments?
Absolutely. So, everyone who's in the clinical setting kind of approaches clinical trials in a different way. What I always sit down and explain to our families is, without clinical trials, we really can't move our field forward. So all of our major advancements in pediatric cancer have really come from, clinical trials and the information that we're able to learn. I think the word trial on its own is very scary, right? Because parents start kind of thinking, if you're not familiar with what a clinical trial is, like, oh, these doctors are going to be injecting medications and poisons into my kids that, they don't know if they're going to work. And one of the really important things to keep in mind with pediatric oncology studies is really, the goal is typically either to introduce something new to help reduce toxicity, or to help treat something that historically has not responded to what we've done. And if something hasn't responded to what we've done, why not take a chance on a new type of technology or a new type of compound to, add data sets and add information to if this could work. The other thing that I think is really important for families to understand is clinical trials. There's different phases of clinical studies. So when we're talking about clinical studies, we're talking about phase 1 to phase 4. And something that I come across quite commonly is families don't quite understand what each phase of studies means. So a family might hear that something's a phase 3 study and not realize that, we've already gone through the safety and feasibility portion that a phase 1 study would be. And we've already gone through kind of figuring out what the dose that's tolerated in kids. And we've already discovered that this actually can have an effect. Now we're just sort of trying to build that really robust information to say that, this is a medication that can move forward into our regulatory processes to really become frontline therapy. So I always sit down, I always try to explain to families, where are we with the study, not just what the actual study is doing. I find that a lot of families will feel way more comfortable about the idea of a clinical trial if they really understand what the question is at hand for the actual study that they're possibly being considered for.
That's something I hear from families who reach out to me a lot is, they're being given maybe a couple different treatment options, or they have a doctor here who's telling them one thing and a doctor here who's telling them another. And they say, Kelly, how do I decide? And I was like, well, I can't exactly tell you what to do. That's not my role, but here's, the data from these 2 options. Here's what we're seeing. Here's questions I would be asking your doctor and both of those teams. But that is hard. And how would you speak to a family who is coming to you and saying, I have the option of doing this chemotherapy, radiation treatment, or there's this new clinical trial with a targeted therapy approach, but there's not a whole lot of data out there on it quite yet. How do you help them decide?
So I think an important thing to remember is that, chemotherapy, radiation therapy, and neurosurgery, those are still kind of our primary frontline treatments for most of our tumors. Patients are really going to be eligible for clinical trials based on, have they either not responded to this, or do they have a specific mutation? And then even the clinical trials that we currently have for pediatric neuro-oncology, the upfront studies are usually a comparative study. So it's either, you might still get the historical treatment, or you might actually be randomized or assigned or randomized to this arm that is the newer type of therapy. And what we're trying to learn in those studies is, are they actually the same, to be able to offer them both up front, or is one actually better than the other? And without kind of that collaboration of the clinical trials, we really don't build the data that's really necessary to be able to tell a family confidently that one option is better than the other. I think one of the things that comes to mind is families, we're the ones that have gone to school for ages and ages and ages, and longer than some of us like to admit, to be able to have the knowledge that we have.
Absolutely.
And I always try to educate patients as much as I possibly can. I tell families, my job as your oncologist is to understand your diagnosis as well as I do. So, depending on sort of how comfortable families are with looking at research and looking at scientific papers, sometimes I'll even pull those in the clinical setting, and I'll kind of look at the curves and try to explain what that means to families. I think the most important thing is that you're maintaining an open line of communication with your physician, and that you're actually asking the questions. Pediatric oncologists, we do what we do because we really love it. It's not a sexy world. It's not a fancy world. And those of us who are in it, we really want to be able to support the families and patients through this horrible, devastating diagnosis that you've been faced with. It's a nightmare to know that your child has cancer, and the more supported we can make you feel as your physicians, that's the most important thing, I think, at the end of the day. So, ask questions, know that we're a collaborative field, because in my opinion, it's sort of, if you have a physician who, that you don't feel comfortable with, your parental intuition is going to tell you this is not the right place to be. And there are tons of folks and tons of avenues where you can kind of reach out. Things like Kelly's role with health advocacy and being the patient advocate for the Sunshine Project, that really, allow different modalities and allow this open line of communication. The other thing is, our field is so collaborative. I can pick up a phone and I can literally call any clinician at any institution, and they will be more than happy to discuss a case. And a lot of folks don't realize how collaborative we are. Ultimately, there are sort of institutions that are known for the care that they provide, but the reason there are so many tertiary pediatric cancer centers is because actually, at the end of the day, a lot of us will actually provide the same care.
I think that's definitely amazing in pediatrics, because that's not how things work in the adult world at all. It's like, no, you can make a consultation and come see me some other time. There's no, hey, what do you think about that? They do some. Where I'm at, I live where the number one myeloma institute in the country is. So, sometimes our docs will call and say, hey, what do you think about this patient or that? And sometimes they say, oh, you could keep them and do X, Y, Z. And then sometimes they say, oh, send them here. We'll do whatever trials we've got going on. But what is something that you wish that more people understood about pediatric brain tumors, and like the families who have to go through living with a child with a pediatric brain tumor?
I think that each and every case is really unique. And each child and every family is a completely different situation than the other, regardless of what the pathology shows. So, you might have two patients with infant glioblastoma who parents have completely different levels of medical knowledge or completely different levels of comfort with the healthcare system. You might have patients who have completely different clinical courses, who have completely different outcomes after neurosurgery, and how you approach each and every piece of that is really important. The other thing that I think is really important to remember about pediatric neuro-oncologists, it's not just your oncologist. We work very collaboratively on a team with other subspecialists who are incredibly important to what we do, and who are incredibly important in helping develop the treatment plans for our patients, and also the help track the survivorship outcomes of our patients as well. So most places you'll have your hub of your pediatric neuro-oncologist, but the pediatric neurosurgeon, the radiation oncologist, the physical therapist, speech therapist, neuropsychology, neurologists, all of these people are just as important as the oncologist in creating a plan for what that's going to be best for the patient.
Speaking of parents with different levels of medical background, I think the ones that have a little bit of background are the most pain. I'm just throwing it out there. Dr. Larkin could probably agree that I was definitely a pain, but sometimes you got to ask the hard questions. And that's something I tell my families that I work with all the time. You know your child best. And if you feel like there's something off or just not right, even if the lab work's not showing or the data's not, showing that, speak up, because, you have to advocate for yourself and your care. And, sometimes that was probably a bit of a pain, but it worked out. All right.
One of the things that kind of sticks out to me really about Riley's story is, you had the medical knowledge to kind of know that, and the mom intuition, right? Because you also knew that something was wrong with the information that you were being told up front, to kind of have that, who do I reach out to? Right. And one of the really, I think, just so important things about what we're doing with the National Pediatric Cancer Foundation is actually the role that Kelly is playing as being just a patient advocate, because it is hard to navigate our world. And when it comes down to it, most of the population does not have medical knowledge, and you're going to trust and you're going to hold on to the words that the very first person who told you your child has cancer tells you, right? And Kelly and I had a lot of conversations in the clinical setting about that. No matter what you're told after, that instant
stuck
sort of gravity of that situation and what you're told will always stay with you. So just kind of trusting an intuition. I think parents definitely have an intuition. If something does not feel right, advocate for your child. You guys are the biggest ones to advocate for your children.
Absolutely. How can listeners support research and advocacy efforts in the pediatric neuro-oncology field?
So something that is very, very important to everything that we do is funding. Every time I meet with a donor or someone who's interested in learning about pediatric oncology, something that comes up is that only 4% of federal dollars that are donated towards research actually go to pediatric cancer efforts. When you think about 4%, that number is minimal. The cost of our preclinical studies and actually transitioning those into the clinical space, some folks would be really impressed with how expensive those preclinical mouse models can be, and how much money actually goes into just trying to develop the science to help support the ideas. So, raising funding, really putting an effort towards getting more word out that such a little amount of government funding does go to pediatric research, I think is incredibly important. And then advocacy efforts, we used to be in a world where no one talked about pediatric cancer, right? It was sort of a taboo thing. And, if you had a child who had cancer, or if you practiced in this field, the first thing you would hear is, oh, that's so depressing, or, oh my gosh, I can't imagine going through what you guys are going through. Like, how do you even get up in the morning? And one of the things that's really important is just that we actually talk about it, that we share our experiences, we share our knowledge as clinicians and researchers, and we have this open format where families and the folks that are helping try to really develop improvements in the field come together and come up with ideas together.
I'll never forget, Tiffany was in Walmart one day and she was on the phone with me and I just heard her go, "Oh, really?" And I'm like, "What's happening?" It was September, which is Pediatric Cancer Awareness Month. And there were pink ribbons everywhere for breast cancer awareness in October. Yeah. And Tiffany was mad. She was like, "It's not even October yet. It's September. Do they not have anything for pediatric cancer?" And I just said, I think we will. I think one day we will. I think we're getting there. I think it's better than it used to be. And the pink ribbons didn't happen overnight either. And don't get me wrong, breast cancer research is super important. I hope that one day pediatric cancer will also be in the forefront of everybody's mind, and they will recognize September and they will recognize pediatric cancer just as easily as they do breast cancer.
But my point with all of that is, if we can do this for a whole month, we can recognize one kind of cancer. Why aren't we recognizing all the other kinds of cancers? I mean, the breast cancer mortality rate has dropped significantly especially after all the funding that's been done from pink ribbon campaigns. So why can't we do the same with all these other cancer types now? Pediatric cancer included with the multitude of other cancers that should be researched and funded, and we're getting nothing for any of it. So I'm like,
and that's the other interesting point, right? Is September we all wear gold or go gold for pediatric cancer, but the color for brain tumors is actually gray.
yeah,
And
that's in May.
It's brain tumor world, right?
Yeah.
So I think just spreading the awareness and just kind of making sure that people are talking about it, not just in September, but year round, and that folks are really getting involved and trying to learn more about what's happening. Because I think once you start understanding what's happening in the research and preclinical world, it just really spurs a lot of excitement and enthusiasm to get involved with advocacy.
And talking about funding, just throwing this out there, and not that this is a bad place, but so many people think St. Jude is the end all be all to pediatric cancer just because they advertise the most. But really, places like Tampa and New Jersey and all over the country have world-class pediatric oncologists, and y'all all have these kind of subspecial, not all of you, but a lot of pediatric oncologists have subspecialties that they're more focused on, and y'all can be all over the country. Y'all aren't all located in one hospital with one group of researchers. This is nationwide, it's worldwide. We need to put more funding into generalized pots instead of all in one basket, because all the best researchers aren't at St. Jude. They're all over the United States. And I think that it's just important for people to recognize that. And every time I tell somebody this, they go, I had no idea. But like, all children can't go to St. Jude. Nora couldn't have went to St. Jude. They didn't have a clinical trial for her there. And I think that's so important that people remember, hey, you may support one organization, but hey, you may also want to support another organization too. So I'm definitely not saying don't support St. Jude, but I'm also saying maybe support other organizations as well. And just look where your money's going, because I used to support a really, really large cancer foundation, and then I found out that their pediatric cancer funding is less than 1% of their earnings. I'm like, you're a $1 billion organization and we're putting 1% into kids. So that's my spiel on funding, is know where your money's going. Like in PCF, 89 cents of every dollar goes straight into research and to the research consortium to help researchers all across the country. So.
And I think that's one of the beautiful things that we do with NPCF is, if you look at the map of our research institutions, that map through the years, that map has kind of initially started with Tampa and South Florida as a huge predominant area, but through the years we've been able to kind of create little points all over the country. So it really is just folks from all over the country bringing their minds together to help move things forward in a really unique way, right? The bureaucracy and sort of the red tape that is involved with some of those other organizations isn't necessarily involved with NPCF. It's sort of, how do we move this forward and what can we do to help?
I love it.
Well, if you could share one message with families battling pediatric brain tumors, what would it be?
I think it's just to have hope and to remember how resilient your children are. I think sometimes when folks are especially doing, things like what Tiffany just mentioned, they're uprooting their lives and they're splitting up their families to get care in a particular institution, when sometimes that care can be delivered right at home with your tertiary oncology center. Yes, delivering treatment to your children is incredibly important, and being with a provider and team that you trust is very important. But it's just a part of the journey. And you really have to just make sure that you keep in mind that other things are there. Enjoy your tiny victories each and every day. You guys both, as parents who have gone through this, know that. God, there's nothing more rewarding than seeing the holiday pictures that Kelly sends every year for Riley, and I share those with people in my office now too. And you guys see those kids each and every day, and you kind of see how they grow and how they develop. So really just making the most of each day.
I think that's a beautiful message to end on. So I think we're going to leave it at that one. But Thank you so much for joining us. This was an amazing conversation, super enlightening, a lot of great information. If anyone listening needs support in navigating their pediatric cancer journey or wishes to be a guest on the podcast, please let Tiffany and I know.
If you want to get more involved with the National Pediatric Cancer Foundation, you can go to nationalpcf.org. We look forward to talking to you again, and take a listen on our next episode of An Unexpected Fight.
Thank you.